We're just going to make sure the recording started. Very good. Okay. As I was introduced, it was very nice to, one second here, we'll make sure we get the right screen up. There we go. I'm here to talk to you for the next hour or so about ECMO, as we refer to it, Extracorporeal Membrane Oxygenation, and its use in ARDS and Cardiogenic Shock. And my goal is to speak to you as the medical director of a large program, but also to speak to you regarding the general indications and outcomes to expect when you consider this technology for a patient. This is a list of my disclosures. None of this has anything to do with extracorporeal support. It all has to do with cardiac output monitoring and large data solutions. The agenda for the next hour is this. First, I want to give you a basic update as to what ECMO is, review ECMO, what the technology consists of, then talk about ECMO for cardiac failure, or predominantly cardiogenic shock, really, and then talk to you about ECMO for respiratory failure. And what you'll find is these are two very distinct groups of patients, and you really can't cross them. Talk to you about the overall outcomes. We're going to do that basically in those two contexts, but then we'll talk about, in general, what to expect regarding this, and then talk about what I think is really important future research in the domain of extracorporeal support and where the research needs to go from where it has been. So the first thing I'm going to tell you is that there's the statistics I'm going to give you in this, it is a very changing field. The numbers that you get from 5 years ago or 10 years ago are not the numbers of today, and hence the truth is not necessarily clear. And what you're going to get today from me is what my perception of the truth may be, and other people may feel differently about that. So first and foremost, what is ECMO? ECMO, as I said, extracorporeal membrane oxygenation, consists of, it sounds complex, it's actually very simple. You basically have a membrane oxygenator of some sort, something that essentially removes carbon dioxide and puts oxygen into blood. You can refer to it as a lung, but it's obviously a synthetic device. There's some type of pump that gets the blood in and out of the patient, and last but not least, certainly is a patient that is allowing you to get blood in and out of them. And that's all it really comes down to. It's an artificial heart-lung machine. How does this differ from what we use in the operating room, I think is the fundamental question. And the answer to that is it doesn't differ all that much, but there are a few novel things with it. First of all, everything on an ECMO circuit is designed to last for weeks. In the OR, we're expecting it to last for maybe hours. And so we really have some fundamental changes to the circuit that aren't really blatantly obvious, except for one of them. But everything in the circuit's designed to minimize blood trauma. So when you go on bypass in the operating room, you create a lot of turbulence to the blood. You eventually wind up with hemolysis. And what we're doing is trying to reduce the amount of blood trauma that occurs. And the way we do that is essentially by reducing turbulence. So the pumps are more smoothly designed, laminar flow is focused upon, anything that has a sharp right angle is removed. All of that is taken care of, in addition to the fact that we use different materials in the actual pump. This results in less consumption of clotting factors and enables patients to remain on support for long periods of time. The big difference that you see is in a OR, we have a large venous reservoir. And the reason you have this is because when we're doing cardiac surgery, there are times where we need to empty the heart out and we put all the blood into a reservoir. And then when we're done with whatever we're doing to the heart, we need to put the blood back into the patient. We empty the reservoir. ECMO is not designed for that. It's designed for essentially maintenance of flow. And as such, there is no venous reservoir, which also means that it's not designed for volume shifts. Meaning, if you need to give someone volume, you need to give it through something other than through the ECMO machine. And that's an important thing. So there are really two forms of ECMO that we talk about. You'll hear us refer to veno-arterial or VA ECMO, where essentially blood is drained from the venous circulation and reinfused into the arterial circulation after it's been oxygenated and the CO2 has been cleared. Or veno-veno ECMO, where essentially blood is drained from the venous circulation and returned to the venous circulation. The VA ECMO is essentially used for folks that are in cardiogenic shock. All right, that would be the fundamental aspect of it. VV ECMO is used for respiratory failure. And yes, there is sort of a gray spot, what we'll come to in a little bit, as to where you may need both. But you may ask, why do you not always use VA ECMO? And the answer is, when you're on VV ECMO, you are able to run with lower levels of anticoagulation. If you have a clot that forms somewhere in the circuit, it is typically small and it goes flying and it creates a very small pulmonary embolism that probably has no clinical effect. If that same clot goes flying into the arterial circulation, it creates a very small clot in perhaps the middle cerebral artery or in the gastric vasculature, and it creates a major problem. And hence, we prefer, if we can, to run veno-veno ECMO rather than veno-arterial ECMO. The key thing to remember with ECMO is it is a therapy that is essentially designed to bridge people to something, whatever that may be, and we'll come to what you're bridging to in a little bit. But it is ultimately not a healing modality. The body heals itself, or we provide a therapy, or we provide some other type of support for the patient, and that's ultimately what gets them better. So ECMO is not a new technology. This was published in 1979 on a trial that was run in 1977 for ARDS. And what you see in the top line here is the survival of patients with ARDS in 1977. So about 70% mortality, just under that. And in the two lower lines are patients with what would be severe ARDS. One group that got randomized to veno-arterial ECMO for respiratory failure because we weren't really keen on the veno-veno concept yet. And another group that got randomized to standard of care at the time, which consisted of incredibly high peak pressures and all types of things that we would never do today. And you can see that mortality was the same at about 90+%. We've come a long way from then in the management of critically ill patients, and we've come a long way since then in the management and the design of ECMO equipment. And what you see is there's been incremental improvement in the world of ECMO, and it's really been focused on the technology that we use to provide this. We have much better devices right now. We have better pumps compared to what we used to have. The tubing is all heparin bound to prevent the formation of clot. We have much better anticoagulation, understanding of what we need when we're doing ECMO and how thin the blood actually needs to be. The cannulas used to be chest tubes that we would cut off and insert surgically. We now have percutaneous devices that are wire reinforced that go in very simply, reducing cannulation disasters. And finally, last but not least, we have a much better understanding of what ECMO can and cannot do and who is a good candidate and who is not a good candidate. Just to give you a brief overview of what's changed in the technology, on the screen here you'll see that on essentially what is your left-hand side, there is what's referred to as a roller pump, and we've since moved to centrifugal pumps and now to magnetically levitated pumps. And below you see what's a silicon oxygenator membrane, which was very tough on blood, that had dramatic pressure differences across that membrane, to now polymethylpentene, which is very, very gentle on blood and can run for literally weeks on end on the same oxygenator. All of this reduces the amount of blood that's used, reduces the amount of cellular trauma, and reduces hemolysis, which dramatically improves the outcome of patients. In the last 7 years, there's been a tremendous change. This is what you see on the left-hand side of the screen is what a circuit when I was a resident at the University of Michigan that still used a roller pump, and all the technology that you see here has a silicon membrane, etc. What you see over on the screen here on the right-hand side, and I don't have a laser. What's here? Do we have a pointer of some sort? Oh, here we go. Excellent. All of this, except for this device here, and this is a little centrifuge, is now in this box, dangling off the side. And this became available in 2010 in Europe. And so this was 2003 right here, and this was the setup we used until, 2005, and this was the setup we used until 2007. So you can see dramatic change in the technology in a very brief period of time. The biggest problem with ECMO was we had technical things to overcome, and there are still technical challenges ahead of us, but this is the biggest challenge that we have, which is the bridge to nowhere, which inevitably, when we're using technologies like this, we get patients occasionally onto. And avoiding the bridge to nowhere is really key because it's difficult for everyone involved, the patient, the family, us as providers, and to the health system, because you can invest tremendous amounts of resources in patients and they end up succumbing to their illness. And this can take months for them to succumb. There was recently a case report of 285 days of support with a woman that succumbed to her ARDS. I actually had the privilege of declaring her dead. So when you get on that bridge, this is actually the bridge you end up getting on, which is a treacherous place to be. You would like to think that you're getting on this large mammoth structure and it's all going to be fine. But really taking care of patients on ECMO is profoundly challenging and really very, very resource intensive. So I'd like to move the conversation now and focus on cardiac support of ECMO or with ECMO. And I think it's important to think about cardiac support in a spectrum and where ECMO falls into this. So what you see here is currently the technologies that are available in the US for the treatment of mechanical circulatory support. There's the intra-aortic balloon pump, which has existed for a long time. And I will talk a little bit about that. And then there are two devices that are primarily designed for left heart support. One's called the Impella, one's called the Tandem Heart. Both are percutaneous in their placement. The Impella just runs up the femoral artery and hangs out in the LVOT and pumps blood. The pump is actually right here. The Tandem Heart will go into a little bit greater detail later. And then there's ECMO. ECMO is the only device that will oxygenate the blood and provide everything that you can do in terms of left and right heart support. Unfortunately, it's also the most complex of the technologies. And so I think it's important to keep in mind when you use this versus when you should use these things. And we'll talk about that briefly. The intra-aortic balloon pump is technology was developed in the 50s, and essentially it increases diastolic filling pressure to help improve coronary perfusion, and the balloon then deflates in systole to allow essentially reduced afterload and increased flow. This technology was felt that it was the standard of care and would never actually be put into a trial, and that it must certainly help people that were in cardiogenic shock after myocardial infarction. It took 40 years, but the trial was done, called the Shock 2 trial, that you see here. And these were patients that had myocardial infarctions that had interventions. And as you can see here, whether they got an intra-aortic balloon pump or not, it did not make a difference in their ultimate survival. And so I think the question that comes up is if you have a patient that's in cardiogenic shock, what should you be doing with them? And should you necessarily be putting an intra-aortic balloon pump in them, or should you be doing something else? And who is the patient that you should be doing something else on? So there are some answers to that. There are some answers to that question. So for example, this manuscript that was published by Seed et al. And looked at patients that were post-cardiotomy that got intra-aortic balloon pumps. And what they found was essentially if you meet some of these criteria right here, a low mean arterial pressure, a high CVP, a high dose of epinephrine, and a rising lactate, if you met essentially 3 or 4 of those criteria, those patients didn't live, all right, 100% mortality. So maybe you shouldn't be using intra-aortic balloon pump in them, maybe you should be doing something else. Similar data from what essentially was a temporary VAD. These were patients that they found when they decided how they were going to put this device in called the BVS. Essentially, they looked at whether if patients were on 3 high-dose inotropes, that those patients were very high risk for mortality. 80% mortality is actually what you wind up with here if you're on 3 high-dose inotropes. So perhaps those patients shouldn't be getting a balloon pump. They should be getting some form of mechanical circulatory support, and they might fare a little bit better. I talked to you briefly before about the Impella and the Tandem Heart. The key thing with the Tandem Heart is what this device does is they actually snake a cannula up the IVC. They puncture, your interventional cardiologist punctures the intra-atrial septum, drains blood from this, and then pumps it retrograde up the aorta. So this is essentially ECMO, what we do with ECMO, except we use the native lung for oxygenation. This allows it to run with less anticoagulation, and it's a very good device, but it takes a relatively gutsy interventional cardiologist to be placing this thing because you can definitely have misadventures that can be fatal. The Impella is an easier device to place, but doesn't provide the level of support that you have with the Tandem Heart. ECMO provides exceptional support. It can provide full cardiocirculatory support, very high flows. This is how we typically place it: a drain down from the IVC, pump it through the machine, retrograde up the aorta, and essentially provides excellent support for patients if they're in cardiogenic shock. This is all that you see at the skin. It's pretty straightforward. You can see the blue blood leaving the patient and the red blood returning. Post-cardiotomy, you can use this if a patient has failure to wean from bypass. This doesn't look nearly as pretty. And what you wind up with is essentially drainage of blood and return of blood using the circuit. These patients tend not to do as well. So post-cardiotomy ECMO patients have very high mortality associated with them, but it is something that can be used to get out of the operating room and offer patients the ability to hopefully recover. So really, cardiogenic shock, what patient should we be using this? How are we defining cardiogenic shock? And there are some guidelines. The Extracorporeal Life Support Organization is the organization that is in charge of essentially development of ECMO. It was founded by Bob Bartlett back in 1988 and has continued to grow. And as you see, they have some pretty clear guidelines on management of patients. Their comments regarding cardiogenic shock are that patients need to have inadequate perfusion manifest by hypotension, low cardiac output despite adequate intravascular volume. I think we would all agree with that statement. And their comment is, if shock persists despite volume and inotropes and vasoconstrictors and perhaps an intra-aortic balloon pump, you should consider the use of ECMO. And I think that seems like a very reasonable statement, although it doesn't offer profound guidance. Let's see here. We'll see if we can get advanced. There we go. Where are the areas where they see this occurring? Typically myocardial infarction or myocarditis, peripartum cardiomyopathy, other long-standing cardiomyopathies that a patient may have, such as non-ischemic cardiomyopathy or decompensated chronic heart failure. And then, of course, post-cardiotomy shock. The other place where this may have a role is in the patient that is profoundly septic, where you are unable to, despite maximal vasoconstrictor support, maintain appropriate blood pressure and perfusion. And so there are some centers that will put patients that are profoundly septic on ECMO for support. The most important thing when you're considering cannulating someone for VA ECMO, however, is the exit strategy. And I think this is the most important thing that everyone thinks about is, what is your exit strategy? And there's this idea of bridge to recovery, which essentially says that somehow that native heart is going to get better. We're going to revascularize it somehow, or the patient has myocarditis and we think they're going to recover, or maybe it's post-cardiotomy and they had bad cardioplegia and we're going to hope that goes away and their heart gets better. There's the idea that this patient is going to need a transplant of some sort. So for example, they've had an MI that's not revascularizable and they're in chronic heart failure, so you're going to try to put them on ECMO and get them a transplant. And then there's this idea of bridge to device, which means that we're going to maybe not get them a transplant, but we'll get them a VAD or a total artificial heart or something along those lines that someday they'll hopefully get a transplant. These are all reasonable strategies. There's also this concept of bridge to decision, which is the idea that you're going to pick one of these three. You aren't quite sure which one. However, you should, when you are considering bridge to decision, you should acknowledge that all of these are in the realm of possibility. If you are going to say, if you have someone that is 85 years old and has had their 4th myocardial infarction and has not been a candidate for a bypass in the past, they're probably not going to recover. They are also probably not going to get a transplant, and you are probably not going to find a surgeon to put a VAD in them. So that is bridge to nowhere. And so I think that it's important to emphasize that bridge to decision, when you hear that terminology, means that all of these things must be on the table. So what are the contraindications to ECMO in cardiogenic shock? This is what ELSO has to say. They say if it's an unrecoverable heart and not a candidate for transplant or VAD, the patient has chronic organ dysfunction, meaning of essentially any other organ which would preclude them from receiving a transplant or VAD. If they have compliance problems, and that may be a number of things. So for example, the schizophrenic that has had 3 suicide attempts is not going to qualify for a transplant or VAD. And so that's probably a poor candidate to put on ECMO. And it's an unfortunate statement, but it's true. And then last but not least, patients with prolonged CPR that did not get adequate tissue perfusion during CPR is probably an important group of patients to avoid putting on ECMO. The relative contraindications, according to ELSO, are that if patients have a contraindication for anticoagulation, you need to seriously weigh that contraindication versus the risks of cannulation. Advanced age, but they do not define advanced age, so they leave that to, and the older I get, the further out advanced age looks. And then obesity, because this can preclude patients from various interventions. So those are important things to keep in mind. There are a number of complications when you put people on VA ECMO. This slide here, I want you to look closely at this line right here. If you look at the pooled estimates, essentially lower extremity ischemia from that femoral cannula happens about 10% of patients. Bleeding occurs in about 30% of patients. But most concerning is neurologic and stroke. These two phenomena occur in total about 20%, somewhere between 10 and 15 usually percent of patients is what's commonly cited. And it's important to keep that in mind. So how does that happen? Well, obviously there's the embolic phenomena that can occur. But in addition to that, there's this idea of what we call differential hypoxia, where what we're doing is we're pumping blood up the femoral artery. And essentially, if the heart is out to lunch, that's fine, all right, because the blood will go all the way up to the arch and get to the carotids. And that's even okay if the heart and lungs are not functioning appropriately. But the problem comes is if the heart starts to recover, but the lungs do not. And what you then have is this phenomena where you get blue blood being pumped out of the heart and bright red blood being pumped up the aorta. And somewhere they will meet. But unfortunately, that may be down here, right at the diaphragm. And so what you've done is perfused the brain with essentially hypoxemic blood and the rest of the body with appropriately oxygenated blood. So the solution to that problem, if that's occurring, first of all, is we always follow right arterial blood gases from the right radial artery, because that way we know the innominate is being perfused. And if that occurs, what we can do is we can use a technology called VAV support. So it's a combination of veno-veno ECMO and essentially veno-arterial ECMO simultaneously. So you wind up with reasonably perfused blood going to the patient's head. The other thing that can occur with ECMO is essentially LV clot formation. Because there's such high afterload from ECMO, is you can wind up with a clot that forms. What you see in the bottom window here is someone's LVOT that's completely occluded with clot. And there's a variety of strategies to treat this, which includes intra-aortic balloon pumps or periodic chest compressions or putting an Impella device in there. There's lots of things that can be done. So when considering this technology, I think it's important to say, when should you consider ECMO? What are the pros of ECMO versus the cons of ECMO relative to other left heart mechanical circulatory support devices? In brief, essentially, ECMO is complete heart support. Left heart's out, right heart's out, doesn't matter, complete support. It provides oxygenation, and if you have a patient that requires high flows, ECMO can do that for you. But it's very complex. There's increased risk of embolic phenomena because of the oxygenator that's sitting there. There's a high risk of bleeding and high afterload. The other devices that exist out there today are very simple, relatively speaking. They provide excellent LV support and drainage. You don't have to worry about LV distension and LV clot formation typically. There's typically less bleeding with them because we run at lower levels of anticoagulation, but they do not provide appropriate protection of limb ischemia. They still provide high risks of limb ischemia that cannot be addressed, and they are limited in the amount of flow that you can deliver. So what are the outcomes for veno-arterial ECMO? If you take a look at these patients, this is what you tend to see. Essentially, you wind up with about 36%, 30 to 40% survival for VA ECMO cases. This was a series that was published back in 2000 out of the University of Michigan. You can see the outcomes that appear there. This is typically the survival curve that you tend to see with these patients, which is profound mortality in the first month, and after that, actually fairly good survival for years. And so I think that it comes down to really, you need to be on trajectory for survival within 30 days. Otherwise, these patients are not going to do well. And so if you're on day 12 or 13 of VA support and you don't have an exit strategy at that point, I think that you can pretty much say, okay, this patient's not going to do well, and you probably need to turn towards a redirection of care to something that's probably palliative. How do these patients do long term? 150 patients. that received VA ECMO, 26% survival to 30 days. A lot of these patients got CPR, so they actually arrested. However, if they left the hospital, their average life expectancy was 9.5 years. So yes, it's an expensive modality. Yes, there's high mortality, but for those that make it, they live a long time. And I would say that this is very similar to a Whipple in pancreatic cancer. So then we continue to do Whipples. So I think that this is a reasonable modality to implement in the right patient population. Of late, what's advanced age? This is a manuscript that was just published out of Mayo of 70 and 80-year-olds that got ECMO post-cardiotomy, typically. And you can see here, they don't do as well as we would like. So what you can see here that survived, discharged to hospital, the entire group had essentially, sorry about that, up here I cut this off, 11 survivors for the 33 people that were for the 36 sorry, 11 survivors, 36 non-survivors in this population. And you can see here that of those 11, half of them died within 2 years. So I think that the 70 and 80-year-old population is probably getting a little too old to be using this technology on. So that is essentially ECMO for cardiogenic shock. For respiratory support, it's a different situation. I know that you're probably disappointed that I wasn't able to show you a bunch of randomized controlled trials and things like that. And unfortunately, that's cardiac surgery, right? ARDS is a different ballgame. And I think there's an understanding out there that we need to study this technology, and it's being run by now much more by medicine people than surgeons. And those folks are focusing on really how should we use this technology. And there's an understanding that there's a lot of options out there for us to manage patients with severe ARDS. I think that everyone now pretty much believes that prone positioning probably offers some benefit in severe ARDS, but it's low tech and it's inexpensive, but it is a lot of work. There are inhaled vasodilators, which I think have very questionable efficacy today, but it may be a good bridging mechanism. And then there's this idea of extracorporeal CO2 removal, which is ECMO light. It will clear CO2, but it doesn't provide enough flow to provide oxygenation, and it has a number of limitations associated with it. And then there is ECMO, or what's sometimes referred to as extracorporeal life support, which provides full oxygenation and CO2 removal. It is very expensive, and it does have significant workload, but it does simplify care considerably. And everyone said for years, this has been done and tried, and it doesn't work, pointing to this slide. Things have changed, however, and ELSO has continued to make progress on this and has some clear indications for respiratory failure. The first of which is they say their opinion is that it should be considered where the risk of mortality is 50% from ARDS, and they consider is indicated when the risk of mortality is 80% or greater. How do you define that? They also say that is a question we'll come to in a minute here. CO2 retention with mechanical ventilation, despite relatively high plateau pressures, patients with severe airway syndromes, and the need for intubation, patient on the lung transplant list. These are the indications for ECMO at this point for respiratory failure. And then there's this idea of perhaps you should consider it in patients with PE or other modalities. So kind of a get out of jail free card. Let's see here. If we can get the slide to advance. There we go. Contraindications also says there are no absolute contraindications. Use good judgment, essentially, is what they say, and accept the fact that patients may not do well. This is difficult to consider because there are a lot of patients where you put them on ECMO and you say this would be a crazy thing for us to do. And so I think it's important to keep in mind that it's important to weigh what people's what the contraindications may be. Things that they do tend to agree on, though, are this. So first of all, patients that have been on high ventilator settings for 7 or more days are thought to be poor candidates for extracorporeal support. Patients that have that are immunocompromised, they say pharmacologic here because there are some individual case reports of HIV patients with PCP pneumonia recovering on ECMO, but the thought that patients on chemotherapy should be getting ECMO when they're profoundly immunosuppressed it's challenging to get them over their insult. Patients that have had a recent head bleed of some sort, and if they have a non-recoverable morbidity such as major CNS damage or a terminal malignancy, should perhaps not go on ECMO. Well, again, they have no specific contraindication on age, but consider increasing risk with increasing age, which I think is a universal truth. So these are the contraindications that ELSO has put forward. Let's see here. In terms of respiratory failure, how do they define 50% mortality risk? They say that that is a patient with a PDEF ratio of less than 150 on 90% FiO2 and something called a Murray score that's 2 or 3. And they say a 80% mortality risk is associated with the PaO2 to FiO2 ratio less than 100 on 90% and a Murray score of 3 or 4 despite optimal care for 6 hours. So what's a Murray score? It's the lung injury score, which we'll try to get to advance here. There we go. And essentially you can compute this using essentially this little decoder ring here. And you look at the chest radiograph, you see how many fields, how many quadrants are consolidated. You take a look at the hypoxemia, the PEEP, and the lung compliance. You get a set score for each of those. You add them up and divide by 4, or if you perhaps aren't able to calculate the compliance for some reason, you add up 3 of them and divide by 3, and that gives you your Murray score. It has not been well validated, but has been accepted by the extracorporeal support community. And why this is important is that the first randomized trial in 30 years was completed in 2009 and published in 2009. It was called CESAR, which essentially was a test of ECMO and an ECMO center compared to best care in other places. This was the trial design. Essentially, patients were randomized using a minimization strategy to ensure good randomization to going to an ECMO center versus getting conventional therapy. And they went to a single ECMO center in Glenfield, England, or Glenfield Hospital in Leicestershire, England, with a group of people that really do a lot of ECMO. Or they stayed at what would be otherwise large treatment centers. And there were 96 centers that they could potentially stay at. They were very large hospitals, however, 500 beds or so. This was the criteria to be enrolled, and you see the Murray score there, and relatively young group of people, 18 to 65 years of age. This was the exclusion criteria, less than 7 days of high pressure mechanical ventilation, no problem with anticoagulation, and no contraindication to continuation of active treatment, whatever that means. And so this was what happened with the randomization. Oops, go back one slide, pardon me. Here we go. So you can see they screened 766 patients, 180 got enrolled, 90 were assigned to go to the ECMO center, 90 were assigned to receive conventional management. Of these, 68 actually received ECMO. Another group did just fine, and we'll talk about it in a second. And they followed up at 6 months with 52 surviving in the ECMO treatment group versus 32 in the conventional treatment group. And this is what the Kaplan-Meier curve looks like. And this was statistically significant. There are some additional outcomes that need to be carefully looked at, however. Of the 90 patients originally allocated to receive ECMO, 3 of them died before they were actually able to get to the center to get ECMO. All right. 2 of them died in transit. All right. 1 of which was due to an actual mechanical failure in the ambulance, and they were unable to supply oxygen. So I think what you learn from this is that transporting these patients is high risk. I mean, this is 6% mortality just from being randomized to say you're going to take a trip somewhere. Of the 85 that actually went to the ECMO center, appropriately spelled for Britain, the 17 of them received what was referred to as gentle ventilation and never received ECMO. And of those, 14 survived. And if you take this group of patients out of the analysis, it's no longer statistically significant. So I think the question is, what did we learn from this trial? Giles Peak, who ran it, would tell you that we learned that ECMO is a superior device and that cardiac surgeons are better taking care of ARDS than pulmonologists. He literally said that at SCCM in 2009. He's a very popular man. Anyway, I think what we did learn was this, is that if you refer people to a high volume extracorporeal life support center, that is associated with higher survival. And I think you can also say that if you did not receive ECMO, that improved your outcome, right? And so I think it's important to recognize that these patients went to a center and they got more lung protective ventilation, they received more aggressive therapy than at the other centers. And that's what you see when you read the Lancet manuscript. The other thing that's interesting is that these patients that went to this center actually had better functional outcomes. More of them were able to feed and dress themselves in 6 months. So I think there may be something to this beyond just the fact that these patients actually were had a slightly higher survival rate from referral, but they actually had better functional outcomes long term, which I think is important to think about. We also, in 2009, had H1N1 come visit us, and this is what we found, the ANZIX group found out from their experience with ECMO, which was they looked at the patients that received ECMO therapy for H1N1 versus 133 that did not. And when they looked at it, essentially they confirmed that a lot of these patients did indeed have true H1N1. A lot of them had influenza that was subtyped, that was not subtyped. And they compared these patients to the 133 that did not receive ECMO. And what they found was this. These patients were young and really sick. The average P-DEF ratio in this group that received ECMO was 56 on 18 centimeters of water of PEEP. The group that they compared them to was nowhere near as sick. They were also older. They had much lower rates of having shock, 34% versus 57%. And they had a slight difference in the number that were truly H1N1 positive. But this is really important here. You can see that there was this inherent bias, right? So these patients had very, very low comorbidities associated with them versus these patients here, 23% versus 8% had comorbidities. So the mortality actually also was worse in this group than this group, but these patients were way sicker, okay? So, but the key thing here is mortality when they followed up actually a year later. We'll skip this bleeding slide for the sake of time. When they followed up a year later, was essentially 75% survival for those that got cannulated for ECMO, which is a far difference from 90% mortality from the data from 1979. And I think that's the key thing to keep in mind here is that this has been proven to be a much different technology, a much safer technology than we had before. This data was also looked at by the British group that ran the ECMO, that ran CESAR. And what they found with their H1N1 experience was the following. They looked at essentially 80 patients that were accepted for ECMO to 4 centers in the UK that were doing ECMO at the time. And they compared them to essentially 195 non-ECMO eligible, non-ECMO referred patients, but they were eligible for ECMO. And they ran 3 different matching algorithms on this patient population. And what they found was this. In every single one of the algorithms that was run, profound survival difference between the patient populations. And this was very compelling data. Again, very young patients that had few comorbidities associated with them. But they did distinctly better according to all 3 matching algorithms. You can see the p-values here are shockingly, significant when you look at that. So obviously the British did it, the French had to do it. So the RIVA study group did this analysis where they did a very similar type of analysis. They looked at essentially a group of patients that did not get ECMO versus did get ECMO, and they did their own matching. However, they were only generated 52 matched pairs of patients. And when you look at their results, shocking that the British and French don't agree on something, I know, but they found no difference. In fact, they actually found a trend towards worse outcomes in the ECMO group. Why is this? Well, if you take a look at the people they excluded from their analysis, they were all young, relatively robust, perhaps they were pregnant, sicker, had an initiation of ECMO patients, and their mortality was 22% versus 50. So they essentially excluded the healthy cohort, the previously healthy cohort that got ECMO from their analysis. And if you do replicate the analysis that was used by the Brits, you see this. So I don't know what the truth is here. I don't think anyone knows what the truth is. I think we can say what we're dealing with right now are lies, damn lies, and statistics, as Mark Twain would say. But I would say that we learned something from this. And what we did learn from the REVA group was this. Essentially, what you do when you're on ECMO matters. So for their survivors, they had much lower plateau pressures than those that did not survive when they were on ECMO therapy. And when you look and see what they got in terms of drive pressure, which I know is all the rage because of the New England Journal manuscript from last month, but this was where drive pressure started to get some traction right here. So perhaps drive pressure is important, and maybe the clearance of lactate is really important to make sure that you have adequate perfusion. So these are the things we learned from that. So overall, what did we learn from H1N1 with ECMO? I think we learned that ECMO is considerably better than 90% mortality, probably 70% if you pick the right patient population, 70% survival. There may be improved survival for those equally sick patients that get ECMO. And patients selected for ECLS typically are younger, healthier people that have fewer comorbidities. And that how we manage patients probably matters. So since H1N1, what's happened? Well, this is the most important thing that's happened of late. First of all, the use of ECMO in the adult population has absolutely caught on fire, 10 times the use in the last 10 years of ECMO in adults, going from a few hundred cases a year to a few thousand. The next thing that we found is that volume probably matters. How many cases a center does probably makes a difference. And if you look at this data here, you can see that centers that do a lot of ECMO put younger people on in terms of age. 51, sorry about that. Let's see the age here. They tend to put, sorry about that. Centers that do more cases tend to put older people on compared to centers that don't do a lot of cases. But they tend to go on much earlier with PDEF ratios of 75 versus PDEF ratios in the 60s. And when you look at what actually occurs in terms of mortality, you see that there's a reduction in mortality for these patients undergoing ECMO. And you can see that it's highly dependent on what type of center you're going to, how many cases you're going to, how many cases you're doing a year. And so this is actually where you wind up with the beta coefficients, and you can see high volume centers. And this seems to be persistent even before technology really got refined. Centers that did more cases had better outcomes. Overall, what are the outcomes in the adult population right now? This is what came out of ELSO last year. The numbers are almost identical for this year. About 56% survival to discharge for BV ECMO patients, 40% survival to discharge for cardiac patients, and this idea of eCPR, that if you got CPR and got crashed on ECMO, about 30% survival. So this is really what you're dealing with in terms of the actual outcomes. So where are we going with this? What are we going to learn in the next few years? This is what we're going to learn. This is the EOLIA trial, which is being run out of France. And EOLIA is the trial that CESAR should have been. Let's see if my slides load here. Criteria are this. You need patients that have been intubated, mechanically ventilated for less than 6 days. So early intervention on patients. They need to have one of the 3 following criteria for severity of disease. They need to have a PDEF ratio less than 50 for greater than 3 hours, or a PDEF ratio less than 80 for greater than 6 hours, or a pH less than 7.25 for greater than 6 hours with a reasonable ventilation strategy. And that's the criteria to put people on, or to randomization. If they get enrolled, they get ECMO incredibly quickly. Within 6 hours of being enrolled is the goal. They use a single ECMO system, Cardiogenic Shock. It's universal. There's no magic recipe in terms of we use the surface pump to avoid the type of complications that may occur. They have the ability to weigh centers mobily, and they can get to those centers in 1 hour with a continuation team. And they will transport those patients on ECMO to an experienced center. And so they are not going to have the transport deaths, and they aren't going to have the enrollment deaths that we're seeing in CESAR in all likelihood. And then last but not least, only highly experienced centers that are doing greater than 30 cases a year are going to be allowed to enroll. We were looking at enrolling for them until it got closed in the US because of the FDA. And last but not least, they're going to really limit the plateau pressures on these patients to provide what's termed lung rest. For the folks that are randomized to the control arm, they're going to get what's acknowledged as the best care possible. That is using the EXPRESS PEEP strategy that was used in the EXPRESS trial, which is a little bit more aggressive PEEP strategy than the typical ARDS-NET PEEP strategy. They're going to limit the plateau pressure typically to 28 to 30. They're going to limit the tidal volumes to 6 cc's per kilo. And this is where the disaster occurs for their statistician, and I am really glad not to be this person, is they are allowing crossover. So your intention to treat analysis is going to be very, very interesting. And unfortunately, talking with Alon Combs a couple months ago, he said that they've crossed over at least 10 patients. So that'll be very, very interesting. And the source of lots of controversy. This is the primary outcome measure, death at 60 days. Secondary outcomes are, as you see listed here. So, in conclusion, and ending precisely at 7 p.m., I think we can say that ECMO is a very complex technology. It's becoming simpler, but it's not quite there to that. I think everybody will be doing this in every hospital anytime in the near future. VA ECMO for cardiogenic shock is associated with really high mortality, and it has a select place in extracorporeal support, and it's important to think about what technology you're going to implement. Just reaching for ECMO will get you out of the jam, but it may not be the best solution for all patients. Transfer of patients with severe ARDS to a VV ECMO center probably does have survival benefit, even if they aren't using actual ECMO. And last but not least, the exact indications for ECMO support are still unknown, and further research is certainly required. And with that, I'd like to say thank you very much for your time this evening. And I think we have a little bit of time left over for questions. So, sure, please. Yes.
Thank you so much, because all of us who are in, certainly who are in critical care, are really interested in ECMO, and we appreciate also your center being available to us for our patients. I have a question about, I feel like your respiratory data for patients who do well or not is very loose, personally. So if I think about Michigan, and I think about H1N1, my first thought is high-frequency oscillation, because you did a high-frequency oscillation evaluation trial there with H1N1.
Correct.
So are we looking at, I guess the thing that I would love to have some guidance on is, when are you saying, even if you're talking about 6 hours, did you move quickly through equipment maneuvers to airway pressure release or oscillation, pressure control, and is that being controlled before patients are placed on ECMO, so that we really have a straight comparative analysis in the end that we're not really going to have anyway?
Right.
So could you
yes, let me repeat the question first. The question is essentially, let me summarize. In EOLIA, it sounds like your big concern is what are the adjuvants that are allowed in the management of those patients prior to being randomized to either ECMO or the conventional trial group. Okay. For EOLIA, they actually leave it relatively they have a relatively good buffet of what you can choose to do. You can choose proning, you can choose recruitment, you cannot choose HFOV, you can choose inhaled prostacyclins, you can choose INO, and you need to have failed those modalities. But you do not have to try those modalities. They are collecting that data. But you do have to fail essentially decent ARDS net ventilation, or express ventilation, which has been proven to improve outcomes in all that other stuff, except for maybe proning. And Alon is concerned about the proning thing because I think he was involved in the proning study too, but when they were getting EOLIA, the protocol through, the proning data wasn't known. So there will be some concern as to what proning does to that patient population. The other thing that's not in there is neuromuscular blockade. I mean, you can choose to use neuromuscular blockade or not, but that may have a big impact. But I think chances are those patients will all get all of that because it's being run in a group of centers that really are excellent at the treatment of ARDS. So I have relatively strong confidence that EOLIA will demonstrate either benefit or no benefit, and there won't be tons of controversy surrounding the other adjuvant therapies. That's what I would say. Even though I think it's kind of loosey-goosey in the protocol, I don't think that's going to be a source of major controversy. So, sure thing. Okay, Michael.
I think one of the things that correct me if I'm wrong, but one of the things that's rather striking with your data is that our prediction models for severe ARDS might not necessarily be the most accurate in terms of outcomes, because there's yet to be any trial data that shows the control group having an 80% mortality rate. And we're making decisions that under the assumption that the mortality is 80%, and that, hey, 50% mortality on ECMO in large case series like an ELSO seems better than 80% or 90% chance of death, but yet we have never demonstrated in any of the control groups a 90% chance of death. I
could not agree with you more. Right. So the question was, summarizing what Michael said, is the control group of 80% mortality a problem in essentially the assumption and the use of ECMO, because there is no trial so far that has demonstrated 80% mortality with ARDS in recent history. You have to go back to 1977 to find that, right? So I think that's an excellent point. And I am not sure that we are at the point where we really know what to expect in terms of mortality for severe ARDS. If you look at the Berlin criteria, you're assuming about 50 to 60% mortality for severe ARDS, and maybe that's what we should be targeting. Well, guess what we have with people that get put on ECMO now, 50 to 60% survival, right? So maybe we're dealing with a much smaller window of therapeutic benefit than we think we're dealing with here. I think this is where we really have the questions to be answered over the next 10 years would be my comment. I think EOLIA is the first step. I would like to see support for advanced research in ECMO and ARDS in particular in the US, and if the NIH would get behind it, that would be great. I don't think that's very likely to happen. And the thing is, I think the NIH continues to fund development of extracorporeal techniques on the basic science level of, can we come up with a better oxygenator? Can we make a better pump? Can we make better tubing? Can we figure out anticoagulation? But the NIH has not said, let's figure out if the technology is good enough and really put it to a test right now. And I think that's concerning. But there's not a lot of support in NHLBI from the chatter I've been getting. Roy Brower was in town the other day and said this will never fly with NHLBI. So the question is how do you study that in the US? And industry might be interested in sponsoring the trial, but this is a very expensive trial to run, right? You're talking tens of millions of dollars to run, I won't say tens of millions, but you're talking millions of dollars to run a trial like this in the US, particularly if you're going to pay for the therapy. So, okay. Other questions? I don't see any questions from our friends at other chapters. So, all right, with that, thank you very much.
Thank you so much, Dr. Blum. It was really interesting. We appreciate you coming. And did everyone who visited the vendors turn in your index card for the raffle? Anyone have one?